As always, we're very grateful, very appreciative for Dr. Andrén's time for presenting this morning. He is a licensed psychologist and postdoctoral researcher at Lund University, Sweden. He defended his PhD thesis at Karolinska Institute in 2022 on the topic of behavior therapy for tic disorders, with a particular focus on remote delivery of behavior therapy. Well, Dr. Andrén is furthermore one of the authors of the European Clinical Guidelines for Psychological Interventions for Tic Disorders. I hand it to you, Dr. Andrén. Thank you.
Thank you, Julian, again for this wonderful presentation, and thank you for having me. We have about an hour again, around 50-minute presentation, and then I'll leave around 10 minutes for questions. And I will share my screen here and also the sound this time, because I will show some video material as I told you in last time. Let's see if it works like this. No, not this. All right. Okay, so program part 2. So today the agenda, we will go through exposure and response prevention, ERP part 2. I will also focus on something I refer to here as a functional analysis and interventions, and it's not actually ERP specific. It could be used in separately or in conjunction with ERP or HRT or other intervention. But it's a behavioral way of analyzing situations and consequences, and try to alter these situations and consequences to make the patient tic less, or at least be less impaired by the tics. And I will go through a few examples of that, how it may be used for patients with tic disorders. And I think if you're schooled in behavior therapy, I think many of you are aware of the basic theory behind this. And then I will end with a few recent studies on exposure and response prevention, a few clinical trials, and then there will be room for questions. And to shortly summarize the part 1, what we talked about last month. So tics are common and often impairing. Tics are usually preceded by unpleasant premonitory urges, and we talked about these and how they may be used in the exposure part of the ERP treatment. Psychoeducation should be provided to every patient that is diagnosed. And then there are several evidence-based treatment options, such as the HRT treatment, the habit reversal training treatment, the ERP treatment, exposure and response prevention treatment, and medication. And ERP, with that, we mean exposure to the premonitory urges, and the response prevention, that is suppressing the tics. All right, starting now with part 2 of the ERP presentation. And here I want to start with giving a little bit of more detail on how you could divide the different sessions and what each session could include. And I will also a little bit later give a few references to manuals, treatment manuals, which you may purchase if you want to read more about this. But this is more or less based on these manuals, which I will refer to later. Sessions, very importantly, sessions should mainly be devoted to practicing ERP with support of the therapist. And this is how the treatments are evaluated in the clinical trial. So you should try to not fall into talking too much about other things during the sessions. It's good to follow up on the homework exercises, but not too long, and try to not, try to get stuck in other discussions and such, because the less you devote to practicing ERP during the session, the less effective the treatment will probably be. That's the theory, at least. But you should provide some new homework assignments, and here are some suggestions for that. So exercise at home, perhaps start with 15 to 30 minutes daily. It could be practicing ERP in situations where premonitory urges and tics usually appear. So an exercise at home where they usually have tics. And then they can also try to exercise in other places. So to give a homework exercise that every week you should choose up to a few situations where the patient can practice ERP, for example, on the bus. And this is just to make it more easy to remember and to be easy to follow up and to make the patient to more easily focus on this task rather than saying that the patient should do it all the time. And the goal here is obviously to gradually expand the ERP practice to more and more situations so that suppressing tics becomes more automated and a part of the patient's everyday life. But to get there, we try to work through this repeated homework, which we try to gradually increase the amount of. But, and the last point here, no one can force the patient to practice the ERP. So it's of course up to the patient self if she or he wants to suppress tics in a given situation. So you can encourage, but you can never really force the patient to do it, obviously. And here's the session by session breakdown. So session 1, and this is kind of my suggestion based on these manuals. So starting with the psychoeducation, the information I provided last month. And I suggest also to write a list of the current tics, so you have something to discuss and something also to compare later in the treatment, see if this has changed. Give the ERP rationale as I presented last time and begin with the response prevention. And possibly for children, use a reward chart if that makes it more fun and more engaging, and especially if the child perhaps is not very motivated or impaired, this could be one way to get the child more engaged. And as a homework exercise, give out the tics diary. They can write down what tics are coming during the week, so you can compare this a little bit to the list of the current tics, and you get something to discuss when they come back. And then to practice the response prevention for at least 50 minutes daily. Session 2, it's possible to do a goal formulation, but this is more common in other treatments such as treatment for an anxiety disorder, obsessive compulsive disorder, where there's actually things that the patient wants or needs to be able to do, especially in anxiety disorders. Patients usually avoid doing a lot of stuff, and then you can set very specific goals to, after this treatment, I want to be able to do this and that. But in tic disorder, it's a little bit more tricky because they usually do not really avoid stuff. They tend to be able to do most of the things, but they're annoyed meanwhile by the tics. And we don't really want to have this kind of goal, where you just say the goal is to have less tics, because it's very difficult to operationalize, and it's also not so rewarding for the patient, because the patient will probably have some tics also afterwards, and it's a little bit difficult to measure. So see if this fits the specific patient, but if you can't find any very concrete behavioral goals which are easy to measure and operationalize and measure, and then perhaps skip the goal formulation. And the response prevention then, session 2, use a stopwatch, record the time. So have a list with the record times if this fits with the patient and the age. And then you can also try to add this functional analysis and interventions I will talk about later. And then homework is to continue 15 minutes daily practice. Session 3, here we want to define and identify the premonitor urges and estimate the severity of the premonitor urges. And this is building up to adding the exposure part to the response prevention. So talking about the premonitor urges, focusing on the premonitor urges and when they're felt, where they're felt in the body. And homework here could be possible to add you wanted to do the ERP and use these intensity ratings of the premonitor urges for at least 50 minutes daily. So they start practicing these ratings and start using this way to think about how intense their premonitor urges are. And then session 4 and onwards is more or less repeating the same thing. And if you want, you could use like an exposure hierarchy, like a ladder, which is more common, as I said last time as well, more common in anxiety disorder treatments. But it could fit here as well if it fits with the patient, just as a way to remember that there are several steps in where you increase the level of exposure. But I think it will be more difficult to do it in this very linear way, because I think more or less you will end up trying to find different exercises, which may vary over time how difficult they are and similar. But if it fits the patient, then this is something you may use. And then the homework is to do the ERP at least 15 minutes daily. And then I also suggest to add this practice outside the a priori plan situations to increase the generalization. All right, last session is to go through the tic diary, follow up on the goals if you have these goals formulated, and do a relapse prevention plan, because this is important. As the final bullet point here, tics wax and wane naturally, and you might need to add a booster and follow-up sessions later. It's important to, if possible, to follow up the patient after the end of the treatment, because it's very typical that tics naturally increase at a later point due to the wax and waning course of tics. So even though if you everything seems calm and the patient seems to have had an effect of the treatment, it's a bit difficult to know with tic disorders if this is something that will be consistent, or if you have actually just found it has coincided with a natural wane in tics. So if you follow up, for instance, a month later or 3 months later, and you offer a boost, then you can see, do you need to add more sessions for this patient to be able to then conclude the patient. Okay, I will now show you 2 films. So one film is demonstrating ERP. It's 8 minutes long, and so you will, to the right, you will have a therapist, and then to the left, you will have a young patient called Kim and her mother to the left. And these are actually actors or actually colleagues of mine who have recorded this. So they're all psychologists. And this is in Swedish, so I've subtitled it. And this is, as you will see, looks a bit old now. It's filmed during lockdown, so they have visors and all that. You remember that. But I think the content of it is still relevant. So I think it's still relevant to show to you, and hopefully the sound will now work. So I will show you this 8-minute video, and then we'll talk a little bit about it. Let's see.
Välkomna till den här demonstrationsfilmen där vi ska visa upp hur man kan öva på ERP under sessionen. Och det kommer jag göra tillsammans med Kim, 9 år, och mamma Maria här. Och det här är ganska tidigt i behandlingen. Kim har fått börja öva på att stoppa sina tics lite. Nu ska vi öka svårighetsgraden genom att jag kommer att fråga om Kims varningssignaler också. Och varningssignaler, det är det ordet vi använder för förkänningar. Eftersom Kim är 9 passar det bättre att använda det ordet istället. Yes, så vi sätter igång. Ja, nu Kim. Nu är tanken att du, precis som vi har gjort förut, ska försöka stoppa alla dina tics samtidigt. Och då är det precis som förut, då är det alla tics på en gång.
Det är jättesvårt.
Det är jättesvårt, men jag vet ju att du har klarat det förut, eller hur?
Ja, men alltså, sen efteråt så var jag alldeles tokig, eller hur mamma?
Ja.
Jag sprang omkring i hela huset och skrek.
Gjorde du? För att det var så jobbigt? Oj, oj, oj. Ja. Det kan vara så. Du vet, när man tränar på att stoppa ticsen, att det tar ganska mycket energi så här i början. Precis som annan träning. Om man ska lyfta en jättetung sån här vikt och så har man inte tränat så mycket. Om man skulle försöka lyfta 50 kilo första gången, då skulle det vara jättetungt. Och då kan man ju bli jättetrött efteråt. Så det kan vara lite samma med ticsträning.
Ja, det var precis så det kändes.
Det var så det kändes, ja. Men det är ju också så med ticsträning, precis som med annan träning, att ju mer man tränar, desto starkare blir man. Och i det här fallet med ticsträning, då är det ju hjärnbromsarna som blir starkare. Kommer du ihåg det? Det är de som hjälper en att stoppa ticsen.
Jag kommer ihåg, jag ska dra åt dem.
Jajamän, du ska dra åt hjärnbromsarna och försöka stoppa alla tics.
Jag lovar.
Och eftersom vi har tränat lite på det här tidigare, och jag vet att du har klarat av det här, så tänker jag att vi ska göra det lite svårare idag också. I början kan man känna sådär, nej jag vill inte. Men jag tror att du kommer klara det också.
Okej.
Och det vi kommer göra, det är att jag kommer fråga om de här varningssignalerna. Kommer du ihåg dem? De här små som känns i kroppen innan
det
ticsen
sitter i
kommer.
benen.
För dig sitter det i benen. Hur är det du brukar kännas i benen då?
Det känns liksom som att det kliar i benen.
Det kliar i benen.
Och sen nästan som att det är sån här, vad heter såna?
Som
Vad heter de?
Myrorna?
Ja, precis.
Ja.
Myror som liksom går inuti benen och biter mig.
Precis så brukar faktiskt många barn som jag träffar säga. Att det känns som små myror som killar en. Och så är det för dig också.
Ja. Jag känner dem nästan nu bara vi pratar om det.
Precis så brukar det vara när man pratar om dem. Att då känns de lite extra
Ja.
starka.
Mm.
Och då vet jag också att när man gör sådär, när man frågar om varningssignalerna, då kan det bli lite ännu svårare att stoppa ticsen ibland. Och då kan man ju undra, varför gör vi det då? Varför ska vi fråga om varningssignalerna om det blir svårare? Ja,
Det blir starkare.
exakt. Då blir hjärnbromsarna extra starka
Mm.
när träningen är svår. Eller hur?
Ja.
Så nu ska vi låta hjärnbromsarna träna riktigt hårt idag.
Okej.
Och precis som tidigare så ska vi ta tid och så kommer vi skriva upp rekordtiderna på tavlan.
Mm.
Och sen så när det kommer ett tics, då stoppar vi tiden och då hjälps vi åt allihopa och se om när det kommer ett tics. Precis som förut.
Men kan vi vänta tills jag är redo?
Vi kan bestämma tillsammans när vi startar klockan, så kan du få förbereda dig lite.
Ja.
Så att det inte kommer helt pang på. Så. Och då kommer jag under tiden också fråga som sagt om hur det känns i kroppen med varningssignalerna. Och så kommer jag ibland be dig berätta för mig hur jobbig den här varningssignalen känns. Och då kommer vi använda en skala från 0 till 10. Där 0 är att den inte alls är jobbig. Och 10 det är så jobbigt det kan bli.
Då är det liksom myrstackar i benen.
Exakt, då är det myrstackar i båda benen.
Usch, det kommer väl inte bli 10 eller?
Vi får se, det vet vi ju inte innan.
Nej.
Vi testar och provar och ser. Och det här är precis som annat. Vi provar en gång först och sen så ju mer man tränar desto bättre brukar det gå.
Och om det är 10, då tränar du bromsen extra mycket ju.
Ja, det är sant.
Exakt.
Uff.
Jag vet att du klarar.
Uff. Okej.
Okej, ska vi börja med om vi nu... Hur känns det mellan 0 till 10 just nu då i benen, skulle du säga?
Vad är skillnaden mellan 4 och 5?
Det kan ju du bestämma själv egentligen. Det finns ingen sån jättetydlig skillnad.
Nej, det är 4,42.
Ja, 4,42 är det just nu.
Mm.
Då kan vi skriva upp det här också. 4,42 när vi börjar. Känner du dig redo?
Vänta, jag ska räkna till 3.
Räkna till 3. Så kan du få trycka och starta
Vad får jag sätta?
Då kör vi! Då är vi igång med Tics-träningen och hjärnbromsen. Är den på?
Den är på.
Du har satt i den.
Mm.
Jättebra, jättebra. Och då tänkte jag höra lite. Där, vet du vad? Där tror jag att jag såg en tics komma.
Nej!
Ögonblickligen. Men du klarade ändå. Ser du hur mycket det är?
Nästan 20 sekunder.
Nästan
Förra
20
gången
sekunder.
klarade jag 35.
Ja. Men den här gången så frågade du om varningssignalerna innan också, eller hur? Så
Men
nu
jag
har vi
ska
gjort
klara
det lite
35 den här
svårare.
gången
Nu har vi
också.
gjort det lite svårare.
Mm.
Okej. Då skriver vi upp tiden här och så kör vi igen. Så får du sätta igång klockan igen.
Är du redo, mamma?
Jag är redo.
Okej. Säg till om du ser det, Tics.
Jag lovar.
Jo, den är igång. Nu är klockan igång igen. Och då undrar jag så här. Hur känns det i benen just nu? Kan du berätta lite igen hur det känns?
Det känns inga myrstackar, men
Nej.
det känns att den börjar liksom komma härifrån och på väg mot knäna.
De kryper mot knäna,
Ja.
de små myrorna.
Så kanske typ 3.
En 3 just nu är vi på. Okej. Finns det någon varningssignal som känns någon annanstans i kroppen just nu då?
Det känns att jag vill rycka med axeln.
Du vill rycka med axeln. Hur känns det? Känns det någonting i axeln då?
Alltså det är konstigt, det känns faktiskt lite i benen av det med, men det känns också här.
Ja.
I den här muskeln att den är, det är nästan som ont på något sätt i den.
Det är nästan ont. Det låter lite jobbigt att det är så.
Får man hålla så här eller är det fusk?
I början så kan man testa sig fram lite vad man tycker fungerar. Men jag tänker att vi ska få prova, se och göra utan. Och där, vet du vad? Nu såg jag en liten näsrynkning som kom där. Så vi stoppar.
Över 1 minut. Det är mitt rekord!
Nytt rekord! Snyggt jobbat, Kim! Och det var trots att vi pratade om varningssignalerna.
Det var jättesvårt.
Jag såg på dig att det var jättesvårt. Det syntes att det var jättesvårt och ändå så kämpade du på och höll i där.
Då måste du berätta det för min lärare sen.
Det ska jag göra.
Superbra jobbat, Kim.
Och det var jättesvårt.
Ja, det var jättesvårt och ändå så gjorde det. Snyggt.
We thank Moa, Helene, and Vera for this demonstration. They were all clinicians in a clinical trial that we did at the Karolinska Institute, which I will talk more about in the very last slides. And they've actually also moved on now to doing their own research. They're all PhD students at the moment at the Karolinska Institute, which is really fun. All right, let's see. So tips. So what they did here, they obviously was an example of how to practice ERP, obviously with a younger patient, and you see the interaction here, and using the timer and writing down the high score times, etc. So here we've written down some tips. Try to make the practice as varied as possible, encouraging the patient to practice in a variety of situations, both at home and elsewhere. And just like with other exposures, for instance, anxiety, it's important to practice regularly to have an effect. So the patient should preferably practice for at least 15 minutes daily. And eventually the patient can be encouraged to suppress the tics in as many situations as possible during the day, because we want to generalize this obviously to other situations. And we try to get the practice into everyday life. So it could be making a rule, for instance, always suppress the tics at breakfast or in the shower, on the way to work, first lesson at school, in the bus, etc. And importantly, make the ERP practice fun, especially with younger patients, because this is a pretty repetitive treatment, because you're sitting there trying to suppress the tics with a stopwatch. It's not much is happening, and it's actually pretty repetitive for the therapist as well. So try to make the practice more fun, especially for the younger patients, to be able to engage them and increase the possibility that this is something they will be using also outside the treatment environment, their sessions. And here are some tips from my colleagues here to how to make ERP more fun. Could be to practice a game while doing the ERP, a fun activity together with the family, and here you can see a few examples of that. Also, I would also like to mention, especially these tic-free zones could be helpful to decide more like a rule with the patient, that when you're in this room or when you do this activity all the time, you should try to refrain from doing the tics. And it could also be helpful to schedule the practice, so there doesn't need to be any discussions each time we're about to practice. So it's pre-scheduled and everyone is aware of what is supposed to happen, and also use a reward chart, as I said. And try to make the parents, inform the parents that they should avoid nagging about practicing, and make a clear arrangement on when and how parents should remind. And you could also involve the child's teachers, coaches, grandparents, etc., and ask them to assist with the ERP practice. All right. Okay, then moving on to the second film, which is short of 4 minutes, and here you can see the same people playing a game called Do This, Do That. And I'm not saying now that all of you should take this to your patients and sessions and do this, do that. It is just an example of one way to make the treatment a little bit more fun, a little bit more engaging. It might not be the first thing you do, but after a while, when you've tried various ways to increase the exposure, if you can find that various fun activities also increases the tics and the premonitory urges, then that might be a good way to actually combine ERP with also fun activity. So let's watch this video as well. It's coming here.
Välkomna till demonstration nummer 2 där vi ska visa hur ERP kan gå till, hur man kan träna på det under en session. Jag har fortfarande med mig Kim, 9 år, och mamma Maria. Och nu har vi kommit lite längre in i behandlingen och har börjat öva på lite svårare saker. Så tanken idag är att Kim kommer få öva på att stoppa alla sina tics samtidigt som vi gör leken gör si, gör så. Och det här är då en lek där vi tänker oss att det är rätt svårt kognitivt. Man behöver tänka till ganska mycket och det gör det ofta svårare att stoppa ticsen. Samtidigt som man växlar aktiviteter och dessutom kan man göra rörelser som är liknar tics lite. Det brukar kunna göra det ganska svårt. Så det ska vi testa nu. Ja, hej Kim!
Hej.
Nu har ju du tränat på det här med att stoppa tics ganska länge, eller hur?
Mm.
Och jag vet ju att dina hjärnbromsar har blivit rätt så starka.
Ja, de är jättestarka nu. Min fröken säger att hon inte ser några tics alls i skolan. Och igår på hästridningen så hade jag bara tics när jag ryktade.
Är det sant?
Mm.
Det är ju helt fantastiskt.
Mm.
Superbra.
Mm.
Vad häftigt.
Mm.
Ja. Så nu har hjärnbromsarna verkligen vuxit. Och då, för att vi ska fortsätta träna hjärnbromsarna när de har blivit så här stora och starka, då behöver vi göra träningen extra svår. Eller hur?
Jo, jag vet.
Ja.
Men det är lite... Ja.
Och det har vi ju gjort hela tiden. Vi har gjort den svårare och svårare och de har vuxit och du har tränat. Så nu har vi kommit till ett riktigt svårt steg. Och det ska vi ju träna på för att jag också tror att du är redo för det. Eller hur?
Ja.
Mm. Och idag ska vi träna på det här med att stoppa ticsen samtidigt som vi leker gör si, gör så.
Mm.
Och varje gång jag gör en rörelse och säger gör si, då ska du göra... nej, nu säger jag fel. Varje gång jag gör en rörelse och säger gör så, då ska du också göra det. Men om jag säger gör si, då ska du inte göra det. Eller hur?
Gör så ska jag göra.
Mm.
Gör si, då får jag inte göra rörelsen. Vad ska jag göra? Då ska jag bara stå stilla?
Ska du bara stå stilla?
Okej.
Och samtidigt försöka stoppa ticsen.
Just det, för man ska ju stoppa ticsen hela tiden. Glömde jag nästan.
Ja, det kan vara lätt att glömma det när det är så mycket man ska tänka på.
Ja.
Mm. Och då tänkte jag att mammas roll idag blir för att hon får hålla koll på klockan.
Är vi eller?
Då får
Ja.
du inte fuska, mamma.
Jag lovar. Ska inte göra det.
Och så hjälps vi åt allihopa som vanligt att hålla koll på om det kommer något tics. Eller hur?
Ja.
Mm. Känner du dig redo?
Ja, jag är redo.
Då tycker jag vi kör igång. Då kan mamma starta klockan.
Vänta. Gör si, då ska jag göra. Gör si. Nej. Gör så, då ska jag göra. Gör si ska jag inte göra.
Ja, exakt.
Mm. Okej, ja, jag är redo.
Då kör jag igång.
Gör så. Gör så. Gör så. Gör si. Nej!
Okej.
Ja, vi
Men jag har
fortsätter.
inte tixat
Du har
än.
inte tixat en enda gång. Då fortsätter vi. Gör så. Gör så. Gör så. Gör så. Gör si.
Nej.
Kom det tics?
Ja, ögontics.
Superbra att du märkte det själv, Kim.
Hur många?
26 sekunder.
Ja, men det var ganska bra.
För att vara i den här leken. Superimponerande Gil.
Tack, mamma.
Exakt, för det har vi ju pratat om förut också. Där, att, men du klarar av att stoppa vissa tics, kanske en hel lektion i skolan. Men nu gör vi det ju extra svårt. Och då kan man ju ha en egen rekordlista för just det här. Som handlar om gör si, gör så. Och då vet vi ju nu att rekordet för det är 26 sekunder.
You're muted.
Thank you, Julia. Okay, so we thank Moa and Helene and Vera again for this demonstration, and perhaps it's a little bit overemphasized demonstration. They're obviously actors, but I think you get the point here that they try to make the practice more difficult. There should be a little bit cognitively challenging to do this at the same time as they express the tics, and also that it could be a potentially fun or a variation, fun way or a variation for the treatment. All right. Moving on now to a little bit of a troubleshooting I added here as well. These are common questions that we get while from patients, families, also perhaps therapists during ERP practice. So the first one is that a tic is extra hard to suppress. So there's a certain tic that is extra hard to suppress, and here we choose to focus on just that tic until it can be suppressed again for 5 minutes. So we switch to focusing on just one tic, and if necessary, use a competing response as in HRT. You could add the competing response. And another comment is that small tics are hard to suppress. Here you can skip suppressing smaller tics when starting the ERP practice, and then you can add them later. So the important thing is that the patient actively practices ERP, not necessarily that they suppresses all tics. So it could be the important thing is that the patient themselves feel the premonitor urge and that they're actually suppressing a tic. Then if there might be other tics coming at the same time that they're not aware of, that might not be as important, at least not to start with. And if the patient does not suffer from the smaller tics, there's no need to focus on them. Another troubleshooting here, the patient does not sense any premonitor urges, and this is very common in younger children especially. Does not necessarily need to be a problem. Here you can potentially work with the awareness training, which is described in the HRT manual, the CBIT manual, and there's a practice there called something like capture the tic. So you sit opposite to the patient, and the first one of you two that notices the tic puts up a finger and say, I saw the tic, and then you get a point or a match or a candy from the bowl or something like that. And then you can practice back and forth and trying to increase the way the patient can try to increase their ability to notice the tic. And if they notice the premonitor urge before the tic, they will always win this game over the therapist because they know when it's about to come. You can also ask how it feels in the body at the place the tic is expressed, and then also start expressing tics and stop halfway and ask how does it feel. If there's trouble with premonitor urges or tics not decreasing, you could focus on suppressing tics in the situations the patient primarily prefers, such as school or other social situations. And you can emphasize that the patient have or may receive increased control over tics, despite that the urges or tics are still many. And you can also connect to the treatment goals if you have formulated those and see if you can work with becoming less impaired or being able to do certain things despite having a lot of premonitor urges and tics. And it could also be the other way around, that the patient shows no tics during the sessions, and it's difficult to practice during the session because for some patients, being a therapist environment, a session actually is an environment where they have less tics. It's a bit individual. So here you could try to provoke the tics and let the patient purposely do the tic movements, look in a mirror, imitate the tics, ask about premonitor urges, ask the patient to imagine a situation where she has many tics, do some physical activity, go to a place where the tics usually come. It could also be that the patient says that they're already used to suppressing tics. This is nothing new. The treatment is what they've been doing for many years. So then you could say that it's potentially a different outcome when the practice is more structured and when exposure is included. because they usually not include the exposure, at least not actively, but could be more passively by going to different places and doing different things. And if necessary, you can add the competing responses as well, as I told you. And it could also be some confusion among parents regarding when tics should be noticed and not. So in general, we don't want parents and other relatives to comment about the tics. They should not comment that the child should stop doing tics. This should be avoided. But what we do want is sharing, encouragement. They could do reminders linked to the treatment. This is more okay. And I think it's also important to have reasonable expectations of the effects from ERP and HRT. We don't want to sink all the expectations so they don't work with the treatment, but it might be good to actually explain that there's currently no treatment that can completely cure the diagnosis. That means ensure that the patient's tics go away completely. And that you could inform the patients about what is reasonable to expect from the treatment. And this could be, I think this goes also for HRT, not just on ERP. So you could expect increased control over the tics, that the patient can more easily control in which situation she or he has tics and not. The tics will probably reduce to some amount, because that's what has been shown in the clinical trials. The premonitory urges will probably not reduce as much, or in some cases not at all. It seems that even though tics reduce, the premonitory urges actually, in studies have shown that it's pretty constant for the patients. But what seems to be easily reduced by these treatments is the tic-related impairment, because then we can also use other treatment ingredients, such as the functional analysis I will talk about now, to pinpoint the impairment. Then you can use more like a broad toolbox of psychological interventions and behavioral strategies. Let's see where we're at the time. 12 more minutes before questions. There's also a way to combine ERP and HRT. I've hinted this already. It's popular among therapists, especially in Europe, to combine the elements for a specific patient's individual needs. And so HRT is using a competing response, a movement that is incompatible with doing a tic, such as folding your arms instead of flapping your arm in a tic movement. And you do that one tic at a time. HRT could then be added to ERP if a patient is bothered by, for instance, a large motor tic, where a competing response potentially could help interrupt the tic. So I think that this is where the combination could be especially helpful when you have large motor tics, especially with arms or legs or parts of the body where it's easy to get voluntary control by doing something else. And this approach has been evaluated in a pilot study in Denmark with some promising results. And with increased clinical experience in a patient group, you might see benefits in combining various elements of a treatment, since they're quite similar to begin with. But I want to point out that you should know what you're doing. If you do not know what you're doing, it's always safer to stick to an evaluated protocol than mixing it up too much. All right, moving on now to the functional analysis and interventions. And I mentioned this briefly in the beginning, that here we want to examine in which situations the tics occur the most, at what times, in what places, during which activities, with which people, when feeling which emotions. If we can pinpoint this, then we might be on the way to understanding when do the tics occur, and can we change this in some way, the situations or the consequences after the tics, if we look at this behavioral chain, functional chain. And here is an example of a functional analysis. So here we've written down the time, Friday. Situation is at home at the dinner table, tired after a long day at school. The patient is tired, and the patient has many motor tics, such as facial grimacing, shoulder shrugging, and arm movements. And here's what happens. Here's a short-term consequence. So the parent says that the patient, can leave the table, and then the child escapes from these situations, and the tics decreases in the moment. But as a long-term consequence, tics are at risk to increase or continue at the next family dinner. And also, the child does not eat enough this day, so there's a risk for more tics in the evening because of hunger and fatigue. So actually, there's several situations and consequences happening in this example. But you get a feeling that there's a lot of tics, and then someone does something here, and here it's the parent that allows the child to escape, and then the tics decrease in a moment, but this might actually have a negative consequence in the long term. So this is just an example, and I will provide a few more examples here. And the basic rule, which is related to this, I've already mentioned this, and it's for family, friends, and teachers. And it's, if avoidable, do not openly pay attention to or comment on the tics. Such attention may increase the frequency and intensity of the tics. Family should not comment, nag, or tell the patient to stop performing the tics. And if the patient himself wants to talk about the tics, then it's okay. And family should instead focus on reminding the patient to use strategies from the treatment, but not so frequently that it becomes annoying. And I mentioned this already enough. And here's a few examples of how this function analysis may be used. I'll give a few examples here. So a lesson in school, if there's a lot of tics at a lesson in school, what to do? Then possibly take a break, see the seating in the classroom. If there's a lot of tics in the classroom, perhaps if there are vocal tics, the patient could sit in the front so it's not so recognizable. If there's a lot of motor tics, they can sit in the back where it's not as recognizable. You can also inform classmates and teachers about tics. If there's a lot of tics during screen uses, obviously try to reduce screen time. It's perhaps not as easy as it sounds, and do physical activities prior to screen use. But I want to point out, it's not always desirable to remove all the fun activities. We don't want to punish the child for having tics. Even if the child has a lot of tics during fun activities, if the patient thinks it's fine, then it's fine. Then it's actually something good for that moment. Homework could be divide the homework, schedule it, do it when the patient's most alert, add breaks, sit in a certain place, help with the homework. At the dinner table, if there's a lot of tics during that, have an earlier dinner and remind siblings not to comment or tease. Getting out of the house in the morning, if there's any difficulties with this, there's a lot of tics during this situation, try to write down a morning routine, pair of clothes and pack the bag the night before, try to have plenty of time in the morning. And this is like common suggestions that would also be useful for a child with ADHD or autism or something like that. Bedtime routine, go to bed earlier, calm activities prior to bedtime, listen to calm music, massage, evening walk. And then if being with friends and the patient gets accelerated, do not necessarily take action in these situations, as I said, if the patient does not want to. However, you can encourage the patient to use the ERP to suppress the tics while at the friend's place. And in general, stress and fatigue tend to increase tics. So trying to reduce stress and fatigue can be beneficial to the patient. All right, I think we're running out a little bit of time, but you can look through all these examples. No, okay, let's say that it's just this one. Let's do this one as well. So the patient, this is actually quite interesting. And I said this was in the example that the patient avoids or escapes from tasks due to the tics. It could be to not have to do house chores, or to not do homework, or to not attend activities. And this might be a disservice to the patient. We don't want the patient to escape things because of the tics, because that might actually increase the tics in the long run. And not consciously, but it might have that effect. So instead, families should try to help so the conditions are as optimal as possible for the patients to be able to. So if you need to go away from dinner table, then the child needs to come back and finish the meal later, and then need to finish the homework later. But you might need to adapt the homework so it fits with the child's abilities. And also, this is also interesting that comfort might also be a risk for increasing tics, especially if the parents or relatives always comfort the patient in direct response to the patient having tics. Then you might actually reinforce the tic behavior by the comfort. So instead, comfort is a good thing, but try to do this during various times during the day or during a special time during the day, which is always the same. So it's not just in relation to having tics. Okay, so here's the summary of today of the ERP part 2. So I have provided a suggested session-by-session content. Sessions should primarily include ERP practice. You should vary the ERP practice and make it fun. You have some troubleshooting, and combining ERP with HRT could be helpful in some cases. And with the help of functional analysis and interventions, tics may decrease. So there's another tool in the toolbox you may use. And then there's this basic rule that families should not comment on the tics. Here's the suggested literature I mentioned. These editions are a bit old now, but I don't think they're actually newer ones of them. And there's actually not any large new clinical trials either. So I think these are what to look for. I think the left one is readily available in North America. The right one can be found at Amazon in the UK if you can't find it elsewhere. Okay, briefly now, a few studies here on ERP. This is a study we conducted in Stockholm in Sweden, and it was part of my thesis. What we did here was that we wanted to check. So all this I've been telling you now, if we do this at a regular clinic, does it work? Like outside a clinical trial setting, a very controlled setting, if we do this in the reality, in the real world, does it work? And we did this at a specialist clinic for Tourette's, so OCD and Tourette's. So it's not at any open clinic or such. But so you should be aware of that. But at least it's like real patients. They're not clinical trial patients, and did it work? And this is the results from the tic severity as measured by the Yale Global Tic Severity Scale, total tic severity score, and you can see it. And they start around 23 points here, which is similar to clinical trials, and then they drop after treatment to around 16 points or so, and then you can see this is maintained during a 12-month follow-up period. So pretty good example, but since this is an open study, we cannot really be sure that this is only because of the treatment we provided. It could also be other factors explaining this, such as time passing, because we don't have any control group. So this could also be a natural improvement over time, that people seek help when they're at their worst and that they improve over time. And then I just wanted to briefly also mention the internet-delivered program we have developed. So we developed an internet-delivered ERP program, which is 10 weeks long, 10 chapters in 10 weeks, and the patients reaches this through an internet module, and then they have they write messages to a therapist, which replies the same on the next day. Back and forth like this, and we did a large RCT in the UK. It's called the Orbit study, and here we had a proper control group. It was a randomized control trial, and we had a proper control and active control group, which is the green line here. They received a psychoeducational control, and then we had the ERP group, and here they were a little bit more severe, around 28 points on the scale. And here you can see the separation in the two lines, and we could see that at the 3-month follow-up here, the ERP treatment was superior to the comparator, but not so much. It's quite small effect size. If you're aware of effect size, is 0.3 is a small effect size. So there was some, you can see there's some improvement in both groups, but there's also still a lot of room for improvement. So they were improved to some extent, but not fully. And then we did a similar, more or less identical study in Sweden as well. And there, actually, we did not find this difference between the groups. So they were very similar, both groups. We had an okay effect in both groups, but we could not conclude that one treatment was better than the other, was superior to the other. So this leaves us, then it's very difficult in an RCT to conclude if it really works, because here it could also be, all these effects could be explained by just time. So people come to the trial when they're at their worst, and then time goes by and they're actually improved, because that's kind of the natural course of tic disorders anyway. The older the patients get, the less tics they have after a certain peak age. So a little bit disappointing for us that these very large, these are actually the 2 largest clinical trials of psychological interventions of Tourette's disorder I've ever conducted, but we couldn't find the effects we hoped to find. But anyway, that's research as well. But a little bit better results for the UK program and the UK translation.